infrastructure and feasibility. I request all the participants to kindly post their questions in the Zoom chat box, which will be taken at the end of the panel discussion. So I request Himanshu ji, please help us.
Good evening, everyone. My name is Ashish Saharia. I'm a hepatobiliary and transplant surgeon in Houston Methodist Hospital in Houston, Texas. And today I will be talking on how to start a DCD program, infrastructure and feasibility. Just to give you a little background about the Houston Methodist program that I've been working since 2007. This is the fourth or the fifth largest transplant program in the country. We do heart transplants, lung transplants, liver transplants, kidney transplants, pancreas transplant, and we are the largest multi-organ transplant program in the country. So we do multiple heart livers, lung livers, and so it's a multi transplant program, and we do a lot of DCDs, and the number of DCDs that we've been doing in the United States has been rising. And when we started the program in 2007, at that time we were doing only uh, about 5% DCDs, and now we currently do about 30, maybe reaching about 35% of our organs are being, and I'm talking about liver transplants, but there is a good 40% of the kidneys are coming as DCD kidneys. So that is our background. And with this, I'm going to start my presentation. So this is Rabindranath Tagore's saying. He says that death is not extinguishing the light. It is putting out the lamp because the dawn has come. So what is exactly DCD or DCDD as it is called in India, DCDD versus DBD? DBD is what we call in India, they call it DNDD, which is it's donation after circulatory death or donation after circulatory determination of death. And the other one is donation after brain death, that's DBD, or death after neurological determination of death. So there are two types of donors. Death after neurological determination of death is by far the largest subgroup of deceased donors, and DCDs is the second largest, is about 30%. But in the UK, it is definitely the bigger chunk. They do almost 70% of their donors are done in a DCD fashion. But in the United States, it's only about 30 to now reaching maybe 40% in some places. And I'm talking about liver transplants and in the different numbers for kidney transplants, different number for heart, and different number for lung transplants. I know in our center they have been doing DCD hearts and DCD lungs, not as many, but they have been doing them. This is the Maastricht criteria for DCDs, and majority of the DCDs which we do are controlled DCDs. That means that the family has decided and the doctors have decided that there is no meaningful recovery for this person because there is trauma to the brain. Either it's from a stroke or from true physical trauma, that a meaningful recovery of the brain is not possible. And so the family decides to withdraw care, and the withdrawal of care happens in the operating room or in the ICU, and we have to rapidly go and remove the organs. Uh, then, of course, you know, the other DCDs are number one is dead on arrivals, or somebody is being resuscitated on their way to the hospital, chest compressions and ventilation, and there is no circulation, or somebody arrests in the hospital and you're trying to do chest compressions. That is a uncontrolled DCDs, and we don't usually use that. Now, when the first heart transplant happened in the world, that was a DCD heart transplant, and that was somebody who had suddenly passed away in the hospital in South Africa. And they did chest compressions on the person, and the person was on a gurney outside, in the operating room, and then they wheel the person without any heart, no chest compressions, and they open the chest and took out the heart. We don't do that anymore. That's not something that is done anymore. Just most of what we do, 100% of what we do, is controlled DCDs. That's Maastricht criteria 3. Criteria 4 is somebody is brain dead, and the brain dead person suffers a cardiac arrest, and that is, and then you do chest compressions, and that is also considered uncontrolled DCDs. So this has happened in India, and this happens in India, and this is an article that I found on the internet from 2017, and this was a liver transplant that was done in a DCD fashion at All India Institute of Medical Sciences in New Delhi. So it's not a new concept. So we need to know that this is not new. And this happens in India. This has happened in India and will probably continue to happen. So this is a relatively recent Supreme Court ruling in India, and this is in January of 2025, and they had talked about what a DCD is. So it reached the Supreme Court of India, and they defined what is DCD and how should a family or a hospital or a group of doctors approach a DCD. So it's very comprehensive, and it talks about creating a primary team of 3 people and a primary team and a secondary team of 3 people who will decide that it is appropriate to use this person uh, as somebody who would we can withdraw care on. And once that determination has been made by both the primary and the secondary team, then you have to go through family consents and do the organ donation after that. And it talks a little bit about withdrawal of care, but it also talks about advanced medical directives and encourages all Indian citizens to go through these advanced medical directives, and all Indian citizens should have some sort of advanced medical directives, which basically allows their family members in these situations to make an easier decision to be able to donate the organs. And this is just a continuation of that Supreme Court order, and it is signed by the Principal Secretary of the Government of India. This was in January of 2025. So this is the outline. It's sort of a little busy slide, but you can see that they go through, the treating team basically sees the futility of care, and hospital creates a primary team that determines that it is okay to withdraw care on this person. Or if they decide don't withdraw care, then obviously they continue taking care of this person. This person is obviously 99% of the times these people are in the ICU. And then once they agree in favor of withdrawal of care, then they form a secondary team, and the secondary team is also 3 people. And then they move on, and then they discuss the process of organ donation with the family, and they get consents. And once they get consent, then they plan on a very controlled DCD. So this is the stepwise way we have to approach, and this has been ruled by the Supreme Court of India. This is again just a continuation of what the Supreme Court had said and how withdrawal of care should happen. And these slides should be available for everyone to read through, and so there's more detail into this. And of course, we have in India, we have the National Organ and Tissue Transplant Organization that is there to support people who want to be involved in doing deceased donation. And all these rulings are there available on the NOTA website also. And this is going through just history, 1994 Transplant of Human Organs Act, and then Transplantation of Human Organs Tissue Act in 2011. India also has this end of life care task force. And this task force is basically an advocacy group which talks about what to do when somebody has reached a point of no meaningful recovery after a prolonged ICU stay. And this society was formed or this advocacy group was formed with a few different societies, ICMR. Uh, uh, ICMR is where it actually published. So there is published material available on end of life care in the Indian task force. And these are different societies that have agreed to all the outlines they have come up with the withdrawal of care and palliative care, etc. So several societies have supported this plan. So just going over this in a little bit more detail. So recoverable brain condition, either a bad stroke or trauma, and the brain tissue is mangled up or swollen, and any meaningful recovery is not possible. A lot of these people are on the ventilator. 99% of these people are on the ventilator, and they have a really poor GCS score. And sometimes here, when they'll have a poor GCS score, or not, say if they have a GCS score of say 7 or 8, then we wonder if this person will pass away after withdrawal of care in a specific amount of time. Because typically, at least at our institute, we like uh, we like a timing of 1 hour from extubation to cross clamps. So we have uh, for the livers, we call from extubation cross clamp. Some people will go by agonal respirations or blood pressures dropping, MAPS dropping below 60 as a point where the clock starts ticking. But at our institute, for the ease of things, we count extubation as times 0, and then cross clamp as the most we would go, and that most we would go from extubation cross clamp, at least for liver transplants, is 1 hour. For kidney transplants, it's 1.5 hours. If you go to Europe and to UK, they have different standards on what timings they want to do it on. But in our institute, it is 1 hour for livers and 1.5 hours for kidneys. And then here, what I'm talking about is primary board and secondary board, and this is basically from Indian context. And full disclosure consents with the family members have to be done. I'm going to read my slide. Family members understand that meaningful recovery is not possible. A full disclosure consent should be signed, which clearly states that the team does not think that the patient will have any meaningful recovery. Families should believe that donating organs will actually help someone lead a normal life. Families should believe that no money will exchange hands or the system will not benefit in any way. And then a little bit about who gets to sign the consents. Um, and they say that if an authorized person is unavailable, then and the patient is incapacitated, then the next of kin or next friend has to, and there is a hierarchy that is set up as to who can be the person who can sign this consent. And this is a hierarchy that I was able to get from All India Institute, and it says it calls spouse or the de facto spouse, and if they're in a relationship or long-standing friendship that they have that they stay together, and like in Texas we call them common law spouses if they're not legally married but they have been living together for years. we will honor their wishes first, and then there are adult children's next, and then the parents and the siblings, and then finally any other person who the decedent has given the power of attorney, or has given them the right to declare them or use their organs or make medical decisions on them. Another thing is that the ICU and the OT nurses and doctors should all agree that meaningful recovery is not possible. Any rumors about wrongdoing by transplant team will only harm everybody. So when a DCD happens in a hospital that is not usually doing transplants, you want to be careful, because you don't want people to feel that the transplant team comes in only to retrieve organs and they're killing people. That is one thing that will definitely shut down the program completely. Uh, Typically, when it comes to who is going to declare the person dead, there so when the withdrawal of care happens, there has to be a doctor. Sometimes here in the United States, we will use nurse practitioners or other providers who will declare people dead. But I believe in India, it'll be a doctor who is not part of the transplant team and should be willing to extubate plus stop all life-sustaining therapy. So if somebody is intubated and is getting epinephrine, norepinephrine, dopamine, whatever life-sustaining measures are being instituted, have to be stopped. And the doctor has to be willing to do that. So you have to find a doctor who will be willing to do that. And that's called the declaring doctor. And they have to basically, once that happens, and then you need somebody to keep a clock. And so what we do here is there are two timekeepers who do timekeeping, plus they record every minute. They will record the heart rate, the saturation, the respiratory rate, and blood pressure. And there is a record that is kept here by two people who will be timekeepers, and they will make sure that everybody knows exactly what is happening. So we get a report every minute as soon as extubation happens about what is happening with the donor, and that helps us because say somebody has really low blood pressures for an extremely long time and they continue to have um, pulseless activity, then we know that those organs are suffering, and we get a little cringy about accepting those organs when there's been no recordable or blood pressure for a prolonged period of time. I have found that use of an arterial line is always very helpful, because when you see that arterial line pulsations flattening out, then the person who's there to declare feels more better declaring the person. The other thing about the doctor who declares the person is that they should feel comfortable ordering a 30,000 units of heparin right before withdrawal of care. So before we withdraw care, we give 30,000 units of heparin, because as soon as blood pressures start to drop, uh, there is a possibility that blood will start clotting inside the organs, whether it is the liver or the kidneys or heart. So we don't want any blood clotting happening inside, and that's why we give 30,000 units of heparin right at the time of withdrawal of care. The other thing, the person who is declaring, the declaring doctor, has to be comfortable giving medicines like fentanyl, Ativan to uh, to the donor, because say whatever degree of mental activity is there, you don't want the person who's passing away to suffer in any way. So you want it as a smooth transition for them. So you give them Ativan and fentanyl to help them transition easily. Extubation should preferably happen in the operating room or on the operation theaters. because you don't want to spend too much time transporting the person from the ICU to the OT, because as soon as declaration of death happens, there is, at least in the United States, there is a mandatory 5-minute wait, and I would recommend that happens in India also, because there's some phenomenon called auto resuscitation and some recorded cases that have happened, and the max time is 4 minutes 34 seconds, and hence the time of no activity or observation, if you would, from the time of declaration of death is 5 minutes. So we have a no touch time for 5 straight minutes where we will not touch the patient and nobody gets no, but we will prep and drape in those 5 minutes, but we won't cut anybody. No cut, not cutting skin, nothing. And we stand and wait. And for a DCD retrieval, you really don't need much. We use 2 towel clips, which is 2 penetrating towel clips, because we want to lift up the abdomen skin and then cut using the knife. We don't use a cautery because there's no need for cautery, because there's no circulation happening. And as soon as we open it up, we put this huge big Balfour. That's the biggest Balfour that's available, that you use, and you really, really retract, and you rapidly go to the aorta just before its bifurcation, and you will cannulate. And the cannulation is usually pretty quick. It's usually 2 people helping. They will hold the guts on one side and one person who's standing usually on the right side, because a lot of people are right-handed. They will hold the aorta with their left hand, make a small cut in the aorta right above the bifurcation with some scissors, and insert the cannula and put a hemostat right behind and start the infusion. Usually we will infuse about 6 liters into the aorta. We start the infusion, but then we have to also cross clamp so that the blood doesn't go in different places. So, or the infusion solution doesn't go in different places. So we will cross clamp right below the diaphragm. And it's a little different when you're doing thoracic organs, but I will not talk about thoracic organs, because when thoracic organs are done, then the cannulations they happen in the chest. I'm going to talk a little bit about abdominal versus thoracoabdominal NRP. NRP is normothermic regional perfusion. Normothermic regional perfusion happens in a DCD when we attach an ECMO machine to either the abdominal aorta or the thoracic aorta. And this is a way to perfuse organs longer, but it's very controversial, because technically what you're doing is reanimating the heart. The heart starts pumping again, and it starts sending blood out to the kidneys and to the liver and to the pancreas and to the lungs. So there is a lot of controversy that surrounds NRP, and you're potentially sending blood back into the brain. And there have been issues in the United States where people have not felt comfortable doing NRPs. But doing NRP really helps the organs get reperfused and becomes a more controlled organ extraction, versus DCD is very, very rapid operation. You're trying to get from intubation to cross clamp in less than 5 minutes, and we do organ withdrawal in less than 1 hour. So there are time limits on how quickly we have to get this done, because the longer we wait, the worse these organs do. So a little bit, this is a flow chart, talks about withdrawal of care and your blood pressure is dropping. And then there is this agonal phase, and this warm ischemia time starts from the agonal phase to when the organs are infused with the cold solution. And then there is a functional warm ischemia time that goes from when the blood pressures are dropped below 50, MAPs are below 50. And it's slightly different for different organs. I talked about it previously, was that it's 60 minutes for livers from extubation to cross clamp and 90 minutes from extubation to cross clamp for the kidneys. And this is specific to our center, and it changes center to center within the United States. But these times are much more in Europe and in UK. And I did touch a little bit about NRP, or normothermic regional perfusion. It's different for the thoracoabdominal organs, thoracic organs, and it's different for abdominal organs. Thoracic people want only 45 minutes of NRP, whereas abdominal surgeons want at least 2 hours. Uh, and this is a little bit more about the UK DCD risk scores, and you can go over these slides when you have time. But this is, we actually as a center have stopped using these DCD risk scores because 100% of our DCDs are put on machine perfusions, and they don't, the value that this DCD risk score held several years ago does not hold true anymore, because the numbers have completely changed after we have started using the normothermic regional, the machine perfusion, normothermic machine perfusion pumps, because we will go in with a high risk group and still have relatively good results. And this is again a little the same paper by Shulgall et al. And they're talking about the UK DCD risk score. And this holds true if you're not using the machine perfusion. But if you're using machine perfusion, then this does not hold true. Or if you're using NRP, then this does not hold true. So I would recommend whatever in India they're doing DCDs, that NRP is instituted every single time, because it helps the organs do a lot better. This is a little bit about our experience, but this is from way back in 2021. We haven't yet published more after we started using the machine perfusion pump. That was in 2021. We haven't yet published, but we know that the number of DCDs that we've done has significantly increased, and we are not using DCDs for or we're using the pump for DCDs, so it's become very different for us. And this is just key points: warm ischemia time less than 60 at 90 minutes, cold ischemia time less than 6 hours, unless you're using NRP. Like previously, when we did not have the machine perfusion, we would try to get the liver into the person within less than 6 hours. And the kidneys would sit a little longer because majority of our kidneys are pumped. And the donor age should be limited to less than 70. That's also been moving quite a bit. Donor BMI should be less than 30, or abdominal CT does not show that liver is fatty. This is also moving quite a bit for us. We don't stick to that too much, but we do look at the CAT scan before we accept the donor to make sure that the liver is not fatty. Recipient MELs less than 25 for livers, again, does not hold true anymore for our center, but any center that's not using NRPs or not using normothermic machine perfusion, I would say stick to lower MEL scores. Recipients of non-retransplant, again, the same thing. If you're not using NRP or if you're not using machine perfusion, then stick to the easier transplants and not super sick people. This is, again, benchmark for DCD livers. It does not hold true anymore for us, but this is just all data, but it's available for you to review in case you're trying to do DCDs without a machine perfusion or NRP. And of course, I just have one slide on DCD hearts. But we do DCD hearts and majority of the DCD hearts that we will do, we will put those hearts on a pump and let the hearts continue pumping before the hearts are put into the human. Again, little limitations on ages: 70 years for kidneys and livers, 50 years for the hearts and lungs. And in India, there are several organizations that are there to help you. Even in Nagpur, where um, uh, we have an organization which is part of, I guess, the Mumbai organization, Zonal Transplant Coordination Center. So just brief mention of that. And now to the real part of the talk about how to start a DCD program in India. I would suggest that start small and become that big voice. So, and I would think that doing DCDs in smaller to mid towns is the best thing to do, because large towns will always be wanting to do a living donation, and but the small and mid-sized towns should be able to do DCDs, and they can start in small, in local private setups, and they can associate themselves with a single government facility which is close by. And there should be education material about withdrawal of care and support and the legal documents associated with it, because uh, people have a lot of misconceptions and people doubt the medical system a lot in India. So there have to be legal documents associated with the education material, and uh, and and then you can create small funds so that you can print material, and you can create and get the beneficiaries of those organs to donate some small amount of money, so you can hold small events at different places, and in places of worship, or in clubs, or whatever. I wouldn't suggest it in weddings, but in different small occasions, people can have a small talk given by somebody who's not quite related to transplants, but a beneficiary, somebody who's received an organ, can go and talk. One thing that I would really, really, really stress on is honor walk and press coverage. So every time we have a donor here in the United States, we will do an honor walk. An honor walk is when the donor and the donor family walks through the corridors and the patient's being transferred. There is a full lineup of hospital staff and whoever is available with their heads bowed down to honor the person who is being a donor, and their organs will be used to benefit so many different people and families. So something that you really have to do is honor walks, and without which you will not do justice to the person and the family who is donating. Plus, you should be able to use this as a way uh, to do press coverage and get people to feel that this is something that should be done. When my body is not useful for me anymore, then the organs that are inside my body should become useful for somebody who needs them. Transparency, 100%. You should not hide anything. They should become very clear as to what that the person who's donating should not feel that somebody earned money out of the organs, and or gained in some other way, or somebody important got the organ before a local person. So all this list should be very clear, available for everyone to see, and they should see blood type list, and that no important person or somebody who has influence is able to get organs before an ordinary person. You have to get NGOs involved, and there are NGOs in India that work towards organ donation, and you can create your own NGOs in your own city. but there are NGOs that have been doing this work, and there are government initiatives that are there. That is, in 2016, I was able to get this off the internet about Pradhan Mantri National Dialysis Program that was initiated. So there are different places that help with all organ donation system in India. So that'll be something that you can approach or create for your own city. Getting neurosurgeons, neurologists, IC doctors involved, and these people will be your biggest advocates. Let them not feel that you will gain in any possible way from doing these transplant or inordinate amount of gains. Of course, you will get paid as a surgeon or a physician for doing a transplant, but people understand that part of it. But if somebody feels that they get extra special, uh, uh, then the people will not accept it, and the program will not be a success. Getting recipients involved, as I talked about, this is again a story from India about somebody who received a heart transplant in 2001, and she's been a big advocate for transplantation. And that's it. So thank you very much for allowing me to do this presentation on DCD. You can email me, write to me, but I will be present for the actual presentation on December 4th. So I should be available to ask questions. Thank you very much.
Thank you very much, Dr. Ashish Saharia, sir, for your wonderful lecture and giving us practical tips about how to start DCD in India. Thank you very much, sir. Now we'll
You're welcome.
begin. We'll start panel discussion, sir. So my first question to Dr. Ashish Saharia, sir. Sir, based on your talk, how different is feasibility of initiating DCD in center that already perform a regular transplantation like is your centers versus the centers where the transplant activity is yet to begin like centers in the India? Please enlighten us.
I think that if the transplant activity is yet to begin, then first thing that really needs to get done is education. So if you do education and education material, you have to basically flood the place with education material, with pamphlets and talks, and have directed talks to the operating room staff and directed talks to the ICU nurses, because they are the ones who will, or ICU doctors, because they are the ones who will feel bad, and they can take bad vibes outside the operating room or outside the ICU, and have bad stories. So you don't want those people to have anything bad to say about disease donation or donation after cardiac death, and they need to see that this has already happened in India and this is going to benefit a lot of people. So I think a lot of education, very directed education, not just pamphlets. So ICU doctors and operating room, operation theater doctors and nurses have to be educated, and they need to understand the steps and how quickly things move, because they cannot take their time in shifting patients and transferring patients. So education will help with that too.
Okay, sir. Thank
So,
you very
and
much.
they also need to feel that the transplant doctors will not have any extra benefits anyway.
Yes, sir. You have explained it very nicely, sir. Thank you, sir.
Yeah.
My next question will be for Dr. Sanjay Kulte, sir. Sir, what are the biggest institutional bottleneck you see when hospital tries to initiate DCD, especially in the Indian setup, sir? How can center overcome these limitations?
Thank you, Amol, for this question, and thank you, Ashish, for a very enlightening lecture. I can I want to just remind you that your lectures during our ISO 2022 went a long way in igniting minds on this concept, and that's what led to the four DCDs that came across in our region after that. So, what we have realized, unfortunately, for the last 1 to 1.5 years, deceased donations, both of both the kind, neurological death as well as circulatory death, have gone down in our region to almost about 20% of what they were the previous year. And what Amol's question now I would like to address here is that the biggest problem here is, as Ashish had mentioned in his lecture, the rumors can bring a program to a total shutdown. I feel some kinds of rumors have done us in, because our donations from all the centers that were pouring in donations for the last 3 years, they have been almost negligible in the last 1 year. So the somehow or somewhere the word has gone across that the doctors are benefiting out of this program rather than the patient community as a whole. So biggest bottleneck is proper sensitization to the concept of death and how this death can be utilized into passing on life to new people. It is somehow not going, the message is not going across all the regions, all the hospitals. There are reasons for not doing donations after death, and their reasons are very valid, and we are seeing them staring us into the eye. At one center, we see the patients are being, the number of patients in the ICU or in the emergency are so high that they cannot be identified as probable or potential donors. And when they are identified and taken into care units, then the patient's relatives feel that the donations are being done, and that is why the patient is being cared for. Otherwise, he was being neglected. So simple things actually are causing the problems. And the biggest bottleneck here in our country as such is the lack of any trails to this program. We had trails coming out from IKDRC and PGI Chandigarh. Somehow they were there, but they were not really very uh, informative to us. And what actually led us to doing this was a big risk taking into the first DCD that we did. But the patient community at large were very supportive, and so we could go ahead with the next three also. So the fear of law, one, and the fear of organs not functioning and the results not coming to probably expected levels. These are the two main setbacks which are actually stopping our community into taking up deceased donation transplantation program. The law is doing its bit in supporting us. The Supreme Court and the Parliament also has now passed the law, but now the type 4 DCDs, what we want to actually utilize, which is the richest source of organs here, that needs to be properly channelized, properly studied, and that is why this series of DCD we are going to have through ISOT through various lectures. I would like to also request Vivek to put his views on this. He also has a program running for on DCD in his institute, and he has a bigger experience than our center. So Vivek, kindly enlighten us with your views.
Right, sir. Thank you for your information. It was also great talk by Dr. Saharia. So we know, all agree that there is an imbalance between supply and demand for kidney and organ in India. Not only in India, but worldwide also. Less than 10% of patients with end-stage kidney failure have access to the organ transplantation. Although India is at number 3 in the world for total number of organ transplantation and number 1 in the world for living donor organ transplantation, unfortunately, for deceased donation, India stand at number 68 in the uh, GODT ranking for deceased donation. And majority of the donor disease donations, they are donation after brain death. DCD cases are very anecdotal. So early our institute, Kidney Institute Ahmedabad and PGI Chandigarh, they have published their initial experience. Despite concern of higher DGA, there is a multiple studies from UK, Europe, US, and our own Indian experience. It shows that at 1 year, 5 year, and 10 year, graft survival between the DCD and DBD kidney is similar. There is no difference. And also patient survival at 1, 5, and 10 year, there is no difference in the data from the UK, Europe, and US study. We have published our experience of DCD transplants, 34 patients. Our 10-year graft survival is 85% and 10-year patient survival is around 70% with a rejection rate of 12%. So the initial experience from India is also promising, and there is need to expand the disease donation with the DCD, especially DCD, because over the last 10 years, the disease donation rate for India is less than 1 per million population. Every year, few centers do more transplants, but if we see the national average, in terms of per million population, it is less than 1 per million population. So definitely DCD will be the cost effective, despite it may require 1 or 2 lakh rupees extra for donor maintenance, or even if we use machine perfusion, the cost of machine perfusion for a kidney will be around 1.5 lakh. So despite all these facts, we can say that DCD will be the more cost effective when, if we compare the cost of long-term dialysis along with the morbidity and mortality on long-term dialysis.
Thank you, sir. Very well explained, sir. Sanjay Kolte sir wanted to say something.
Yeah. Ashish, may I please ask you how and what percentage of your patients you do by rapid retrieval technique, and what percentage of patients do you normally use NRP?
Our NRP usage is very low, actually. But I wish, just because, so I would say about a 5% NRP, but rapid retrieval is usually about 90-95%.
So I presume most of the DCDs that you do is majority of them are limited to the abdominal organs.
Yes, that is correct.
Okay, so
But
thoracic
because of machine perfusion, a lot of heart transplants and lung transplants are now happening from DCD donors also. And even our institute, that has been, actually, I would put our institute as a backward thinking institute in terms of using NRP, because there were some lawsuits and there were some issues, and so people have retracted back from NRP a little bit. But it's going to come back, because it's a better way to have DCD donation. But also our institute does a lot of machine perfusion, and because of that, we don't get super excited about doing NRP. But when we do machine perfusion, that's a big extra cost for us. But the hospital is more used to it, so we have usually stuck to using the machine perfusion instead of NRP.
Sir, that in countries like India, not all the centers have an access to ECMO or NRP like facilities like you have. So what alternative retrieval pathways can still ensure a good results without full NRP capability, especially in
Machine
Indian context, sir?
So like, we don't use, as I said, we don't use as much NRP at all. So, but we use a lot of machine perfusion. So if you can have, especially for kidneys, 100% of the kidneys will go onto cold perfusion machines. And when you retrieve the kidneys, you just need to make sure the cuff of the aorta is big enough that will fit into the machine. But that is all I would say, is that just put, and these don't have to be special machines. They're just cold perfusion machines, non-oxygenated cold perfusion machines. And just their usage delays makes it delayed graft function results better. So you don't get as much delayed graft function when you do machine perfusion for the kidneys. And I'm guessing that machine perfusion kidneys is not going to be very expensive.
Sir, thank you, sir. My next question is to Dr. Sanjay Kolte, sir. Sir, in India, one practical roadblock is psychological. You have witnessed during our allocation process also. Generally, team feel DCD is complex or high risk. Based on today's discussion, how can we build a confidence for centers attempting their first DCD, sir?
We rightly have to actually sensitize the people in the ICUs where the deaths usually happen. They have to be given a fair idea about uh, gaining another perspective towards death. Normally, when a death is impending, their attitude is quite of giving up, and they would start counseling the families into probably allowing them to either uh, uh, take them away for to a higher center, or be prepared for the funeral and other activities. They have to be given an insight into this concept, the realistic view of how donations can really uh, transform lives of some people who are otherwise going to die anyways. And the very fact that donations like these, they will not cause any harm or any disadvantage to the person who is dying, that thing they have to actually take it to their heart and realize that every death that happens in the ICU must be always looked at with two perspectives. And the first amongst them should be to see if these organs can be definitely of any use to the patients of organ failure. They have to come out of this routine mindset of just certifying deaths and handing over the mortal remains to the patient's relatives. They should see this as a very real concept and something which is selfless and for the benefit of the society at large. After them, then the paramedical staff who deal with deaths in the hospital, they should be sensitized. And then commonly we should, as Ashish also believes, like we did in our own patients also, honor corridors and the honor passages to the funeral process of the donor. They also have a very high impact, and we have seen it in our own aims that was happening. It was literally the first and the second DCDs. They were sensitized, and they were actually encouraged to allow donation once when they saw the honor that was being accorded to the one of the donors who was that time provided with such a honor corridor. So these are small things, and majorly the medical community has to perceive it as a real possibility, and the society at large should realize that it is for the benefit of the society at large and not for the doctors per se.
Yes, sir. Sir, thank you, sir. My next question is for Dr. Vivek Kutte, sir. Sir, based on your understanding of India's transplant landscape, which type of center or cities are most, you think, most ready to begin or expand DCD in upcoming years, sir?
So on this year on Indian Organ Donation Day, AIMS Nagpur and GMCH Nagpur, they were awarded recognition award for their contribution to the disease donation, including DCD. So similar success can be replicated in other centers and other states also. So if we see like Telangana, Tamil Nadu, Karnataka, Maharashtra, and Gujarat, these are the top 5 states for disease donation transplantation in India. So any tertiary care center from these states which have access to the 24 by 7 ICU care, access to the theater for rapid retrieval and transplant. So these centers can do the DCD transplants. And other low volume centers, they can follow the success stories of these transplants. So any center which comply with the Transplant Human Organ Act, Supreme Court guidelines on withdrawal of life support, and DCD position statement published by Indian Society of Organ Transplant, Indian Society of Critical Care Medicine, along with other stakeholders, they will be able to do the DCD transplant without any obstacles.
Yes.
May
Thank you, sir.
Amol, may I put a question to
Yes, sir.
Ashish?
Yes, sir, please.
Ashish, are you around? Yeah.
Yes.
Pardon my ignorance, but
No, no,
this machine perfusion that you speak of, do you can you suggest us uh, uh, a slightly affordable method in instituting this machine perfusion? We are not really aware what kinds of machines are there, and do you feel comfortable doing a liver also with these machine perfusions normally? And do they really work as well as the brainstem death donor livers when you perfuse them with a normal machine perfusion?
Yes, so let me talk about the kidney perfusion machines first. So kidney perfusion machines, I think the ones that we use are fairly cheap machines. And we use the only thing that once you buy the machine, the only thing that you're changing is the inside console, which is a pretty small console, and the solution that you put in is just a small amount of UW solution in it, and it basically is a small pump that pumps cold solution inside. It's a small refrigerator. It keeps it, and it measures flows and resistance. So it's a flow measurement, resistance measurement, and temperature regulation. These three things are done on the machine. It's like a small refrigerator with a small pump on it, and it's I won't call it crude, but I think it's a simple pump that can be made if you don't have true access to it. But I can send you the names of different machines, different companies that make that. And I bet there are some competitive pricing on this too, and that is available. But for the livers, 90% of the livers that we do now are done on machine perfusion, but we are using the most expensive machine perfusion. We use the Transmedics OCS pump, which uses 5 units of blood, and it maintains temperature, normal thermic temperature, and we measure lactates and bile production on these livers when we transplant them. But that's a very expensive machine that we use, but that is just because our hospital has become used to it, and we were part of the initial trial that was part of the Transmedics trial. So because of that, we got used to using their machines, but it has definitely helped the number of transplants that we've done. Our transplant numbers have gone up almost 30% just because of the machines. So this year we've already crossed 300 transplants because we are using more and more machines. The number of livers being rejected for livers being fatty or livers being from older donors, that concepts are now going away with the use of machine perfusion.
Can a heart lung machine be made into
Definitely,
use?
you can repurpose a heart lung machine into what I just described. But
Right.
it requires some mechanical changes in the machine, and
Right.
even an ECMO machine can turn into a machine that'll do the same thing.
Right.
Yes.
And if you have like some old heart lung machines that they're trying to dispose of, or they have new machines that have come, we can repurpose the old machines into being used as to perfuse organs.
Because all the
Especially
4 DCDs that we have done thus far has been a very crude method of perfusion. We have been, manually compressing the bottles, and that way we have managed to do only kidneys thus far, and the liver guys were not.
So describe, so you had, when the kidney is retrieved, then you will just continue perfusing with bags. Is that what you suggest? Okay.
Right. Yeah.
Yeah, I mean that is very. I mean, obviously you can do that. It's better than not doing it, but that's very manual intensive. It will require a lot of work from people around. But when you're transporting, how do you hold the solution? But it's a good solution. It's a good idea to do it, but it's definitely
Uh,
harder.
Yeah, I think with this repurposing of a heart-lung machine would be feasible in our kind of
Yeah.
setup. We can probably look at that in the immediate future. Thank you, Amol. Over to you now.
Yes, sir. In the same context, sir, Dr. Arpita Roy Chaudhary ma'am wanted to ask the same question, sir. You have just answered like normal machine perfusion available in cardiac facility, like just you answer heart lung machine. Is it a low? It is a low cost and it is widely available in India because bypass is going in many of the
Yeah.
cardiac centers. So can we use it? Is it a good idea?
It's definitely a good idea. You just have to create a sterile chamber where you can put the organs and cannulas that can be inserted into, say if you're inserting, you're trying to repurpose it for a kidney, then you'll have to get the correct pressures. Usually the normal system, you'll probably want uh, pressure regulation, flow regulation, and temperature regulation. You can do all three with your machine, with your heart lung machines. And you can use in a heart lung machine, you can use oxygenated blood, or you can use oxygenated perfusion solution. That could be just plasma light or lactated ringers or whatever you want to use. You can use that, and you can oxygenate that blood, a blood or solution, whichever you want to oxygenate.
Thank you, sir, for such enlightening answer, sir. Sir, this is for Pute, sir. Sir, there is some anxiety among nephrologists regarding delayed graft function and outcome of the DCD kidney transplant. Based on global or Indian context, how would you reassure clinicians about the DCD outcome, sir? And in the same context, Dr. Manoj Dhanorkar also wanted to ask you regarding the pre-implantation biopsy, uh, basically in the context of saying the fear of graft dysfunction, sir.
Yeah, so there is a concern of marginally increase delayed graft function in DCD, but this depends on warm and cold ischemia time, donor management, especially hemodynamic management, and also donor age. Our published literature has shown that the 10-year outcome of the DCD from India and also multiple cohort studies from UK, US, Europe, they have shown that 1, 5, and 10-year graft survival and patient survival, despite higher rate of DGM, is similar in DCD versus the DBD. So we can manage the higher DGA with better donor management, especially hemodynamic management, rapid access, better ICU care, proper retrieval technique, and also use of machine perfusion. They can decrease the DGA. In India, we have two options. One is the LiPort machine, where cost of kidney is around 1 to 1.5 lakh, and other is the Vita Smart. The cost is around 2.5 lakh. The advantage of LiPort machine is that we can use live put during transport also. For example, if retrieval is taken place at remote place, we can use the live put machine during transport as well. So with the better management of the donor and availability of the machine perfusion, or even well organized static cold storage, there is no concern about the DGA. The long term outcome is similar between DCD and DPD, and we need to implement this in a scenario that there is a worldwide shortage of organ with less than 10% have access to the organ transplantation.
Thank you, sir, for such insightful answer, sir. Sir, now this my final question is to Dr. Sanjay Kolte, sir. Sir, while declaring brain dead, many time we see that second apnea is not happening or patient is not suitable for the brainstem dead declaration. How can we tap this missed opportunity, or how can we use that opportunity to convert into the DCD?
Once we have a single apnea test done, we probably are legally authorized to counsel the patient's relatives into donation, and if they have consented for donation, there is no reason why they would not consent for a donation after a circulatory death as well. So if such a patient, such a donor, if he doesn't permit, unfortunately, the second apnea test, and if he collapses, then the laws pertaining to the DCD certification, they come into play, and a 5 minutes of total asystole followed by our reperfusion of the organs can allow us to take up these patients for harvesting of the organs as a DCD donor. In fact, legally, this is the safest pool of patients who can be taken up for uh, harvesting organs as DCD donors. And I think 3 out of the 4 that we have done this far in Nagpur have been such patients only. And so that way they can be taken up. And fortunately, in such patients, we also have the recipient pool ready with us because after the first apnea, we have already uh, alerted all the patients on the waiting list. So there is no problem in finding recipients for such organs. So this is probably the lowest hanging fruit for anybody who intends to do or begin DCD program in their setup.
Thank you, sir. With this, this has been a truly enriching inaugural session, sir. The key message is clear, sir. The DCD is feasible in India with proper workflow, training, and teamwork. On behalf of Indian Society of Organ Transplantation, I want to thank you, Dr. Ashish Saharia, sir, Dr. Vivek Kute, sir, and Dr. Sanjay Kolte, sir. I also wanted to thank all the attendees for today's programs. And we look forward to you next first Thursday of next month. Thank you very much, sir. Thanks a lot and good night. Thank you very much, sir.
Good night. Good night.
Thank you, sir.
Thank you
Thank
all.
you.
Thank you.
Thank you for that.
Bye. Bye.
Thank you, sir.
Good luck. Bye.
सर बंद कर दो।